but you get it if you're severely immunosuppressed. The last case, I've seen 3 cases in my career. The last case was one of my colleagues. Unfortunately, he had a patient with a liver transplant, and she developed a type of kidney disease called FSGS, and my friend wanted to treat her. I don't think he did anything wrong. He gave her a little more prednisone. That she was getting already Imuran. She was getting Celcept. No, I'm sorry. She was getting Imuran. She was getting tacrolimus. She was getting prednisone. And the only thing my friend did, he increased the prednisone. And the lady was a diabetic. The next thing that happened is that the lady came with epistaxis. It wouldn't stop, so we called ENT, and actually the ENT doctor went in and he stepped out of the room. I wasn't called that week, and he told me, okay, this is not good. Like, why? I guarantee you this lady has mucor. Like, the destruction, it was basically the necrotic tissue, and the nose and the palate is pathognomonic. So he knew for a fact, without even having the slides, that he was dealing with mucor. This disease, actually, very few people survive, like I said, and you need to treat him aggressively. They need to actually, this lady ended up getting like a enucleation of the eye, and they remove all the orbit, and after 6 months she ended up dying. It's you treat it with amphotericin B and aggressive surgical excision. So mucor, no good. Always remember that. This is mucormycosis. So I'm going to leave you the fungal question so we can move on. Okay, so TB, you guys all know about the diagnostic criteria. Now we have the quantiferon gold that wasn't available 10 years ago. Like now, for patients that actually have an allergy to the PPD, or those patients that actually have a positive PPD, we end up doing the quantiferon gold. If you have important things to know for your boards is that if you're taking steroids, you need to call, you need to actually have like if it's greater than 5 millimeters, then you call it like a positive PPD, because these patients have an impaired immunologic response. And for me, I get it every year. They measure up to 10 millimeters. So recently my son got it, and I don't know why the pediatrician did a PPD, and he tested positive, and they ended up doing a quantiferon gold. Unfortunately, it was negative. So I don't know why we just stay away from doing PPDs, because it's a lot cheaper, but it also requires that the patient comes after 48 or 72 hours of getting it. So TT, repair children, yeah, so these are the cross-wear one blood draw. Yeah, this is for screening. You guys, this is not going to be on your boards. Latent TB infection. So now, one thing I forgot to include here is that the protocol is 9 months of INH. Now we have it's not observed, it's actually a shortened duration, is only for 12 weeks, and you get a weekly dose of anti-TB medicine. I don't know what the regimen is, but for your information, if you or your loved ones or any of your patients end up having TB, latent TB, you can refer them to get the 12-week treatment. If I end up coming positive for latent TB, I'm definitely going to do a weekly treatment for 12 weeks. It's actually FDA approved for the last couple of years. Okay, so TB, you're going to see it a lot if you end up working in a community hospital. I'm sorry, in a teaching hospital. And you don't see it that often in the US, but you do see it in immigrants and other populations. HIV, transplant recipients, dialysis patients, actually a risk factor. And these patients, you need to have a high clinical suspicion, because they may have like a chronic, very slowly progressive disease. And these patients represent a public health risk. They're coughing and they're spreading these organisms. And every time you get a new diagnosis, they end up screening everybody. So last year in my dialysis unit, we got a patient that tested positive. Everybody in that unit needed to be tested. It was a nightmare, including the physicians and everybody, because the patient was coughing for months before we ended up diagnosing him. Okay, so the chest X-ray, usually look for apical infiltrates or any cavity formation. The pleural biopsy is actually if you cannot get a diagnosis with an AFB, a pleural biopsy is almost always diagnostic when the patients have like pleural changes. These are the treatment. I'm not going to talk about this. This is complicated. There are different regimens. You probably need to know these at one point, but not for your step 2. Okay, Nocardia. This bacteria is actually an opportunistic gram-positive branching rod. It forms abscesses. One of my best friends, his dad was a peritoneal dialysis patient. He had a soft tissue trauma, and that got actually a superimposed Nocardia infection, and he ended up developing meningitis, and he died from it. It was very sad because the disease basically progressed in a matter of like 2 or 3 days. These patients, you treat them. The most effective antibiotic for Nocardia is trimethoprim sulfa, but I don't think you're gonna get that on the boards. But I just put it here. Tick-borne disease. We have the more common tested on your boards are the Rocky Mountain Spotted Fever, Lyme's disease, Ehrlichiosis. I think it's in the East Coast. I've never seen that in the West Coast. And these are the other 4 that, like, I've never seen. The only ones I've seen is Lyme's disease, but he didn't contract it here. And the Lyme disease. I've never seen Rocky Mountain Spotted Fever. So, but they ask you this question on the boards. They tell you how long the tick was attached. If it was attached for 1 hour, this is not going to be Rocky Mountain Spotted Fever. It's like at least 6 to 10 hours. The incubation period is about 7 days, and the patients develop this petechial rash, and they can get very sick. They can get thrombocytopenia, elevated LFTs, and then the diagnosis is clinical for those physicians that are living in these areas. They're probably very familiar diagnosing this. You know, when you suspect it, you start treating it. Doxycycline is the treatment of choice, and basically the death rate for those that you don't treat timely is pretty high. When I was I'm going to share something interesting. When I was and because I learned 2 things from that case. When I was at Olive View, the girlfriend of one of the urology residents, she got admitted to Olive View. She didn't have insurance, and the lady was super sick. She was septic. And it was one of my ID attendants that saved the lady's life, because he was able to diagnose her with what's the name of that condition? The Yersinia. What's the name of I have a slide here. Plague. Yersinia pestis. So here's the thing. The lady became very, very sick. And my attending was able to diagnose like the conjunctivitis, all the clinical features, the elevated, the transaminitis, and it turned out that the lady actually she adopted a pet possum. I didn't know that people would have possums as pets, but apparently the pet possums, they actually carry the flea that is associated with this disease. He really saved her life, because had not he diagnosed her and started her on doxycycline, the lady probably would have died. Because what are physicians doing? They're just giving like conventional antibiotics, cephalosporin and things like that, and that's not the treatment for Yersinia pestis. Okay, Ehrlichiosis, it's in the East Coast. It's like a rickettsia-like bacteria. Patients have like pancytopenias, elevated LFTs, and usually, again, this is a tick-borne illness. And they call it the spotless Rocky Mountain Spotted Fever. So always remember that, because the last time I took my boards, this is a touchscreen? Mm-hmm. I didn't know that. Okay, last time I did my boards, I did get a question about Ehrlichiosis. Okay, other zoonoses, you already know, we already talked about Q fever. I'm going to skip Q fever. Brucellosis, you know, people, a lot of people in this country actually, they buy goat cheese from Mexico. If you guys do that, don't do that, because they don't pasteurize the milk, and brucellosis is actually a real risk. I've seen it. I've seen 1 case in my career. These patients present like very non-specific symptoms like fever of unknown origin, failure to thrive. They can develop like joint involvements, and it's very challenging to diagnose that, because they rarely grow in blood cultures. And sometimes they just require like a very, very expert infectious disease doctor. But again, dairy products, unpasteurized dairy products. Leptospira, I've never seen any. Oh no, I saw 1 case, and usually rat urine and feces. If you have a patient that looks very sick, he has conjunctivitis. If you have a patient with transaminitis and typical exposure, like some sort of like eco challenge or adventure racing, or water rafting, or like I said, like exposure to rat feces, you need to actually start treating these patients. It's a serological diagnosis, and you treat them with penicillin and doxycycline. Malaria, you guys are never going to see malaria in the US, but they ask you on the boards. These patients, actually in Colombia and Venezuela, is very common. These patients there's two types of malaria. The one that you need to know is the falciparum and the vivax. The vivax is treated a little bit different because vivax can actually have a phase of the disease that actually can stay in the liver, and it can come back at a later time. But these patients, they usually present with very severe fever and chills and sweating and tremors it coincides, the tremors coincides with the time that the organisms are actually replicating. And this disease is actually serious because it causes like severe hemolytic anemia, and the patients can actually end up dying from complications of this. You're not going to see this in the US. It's usually transmitted by mosquito, and it can also be transmitted by ticks. But I've never heard of the native malaria case in the US. Okay, so later has been special attention to bioterrorism agents in your boards. So important things to know is the anthrax. You guys remember, like shortly after September 11? You guys remember? You were still in high school probably, even younger than that. So there was a guy who, I think he was one of the physicians or one of the PhD researchers at one of the labs. He was the one sending him. I think that's the last thing I heard from that case. He committed suicide before they were able to prosecute him. But shortly after the September 11 attacks, they started like sending a lot of anthrax in envelopes to different like people here in the United States. Fortunately, nobody. I think he was able to kill a person with the inhalation with the spores. It went into his lungs, and the patient died. During that time, I remember very well because during that time the stock for the company that makes Cipro like skyrocketed. It was crazy. Like everybody was trying to buy like Cipro stocks. I remember during those days. But the bottom line is that they may ask you these questions about bioterrorism agents. So it's a typical boxcar shaped gram-positive rod. If you see this picture, immediately these patients can have like severe like soft tissue involvement in necrosis, muscle necrosis, and then mediastinal widening when you inhale it. The other bioterrorism agent that they may ask you is the Clostridium botulinum. That's the neurotoxin. We use it in medicine. There's some clinical practice, there's some clinical use for this toxin. The same thing that they did like with Botox. But death usually occurs from respiratory failure. I'm not aware of anybody dying in the US from this, but it's being considered a bioterrorism agent. So it's important that you guys, if you have a case with symmetrical descending flaccid paralysis, you think about two things. You think about you think about Guillain-Barré, and you think about Clostridium botulinum. The difference is that the Guillain-Barré patients are usually in ascending. It's more like distal to proximal, whereas this disease is actually more like descending, flaccid paralysis. And these patients have like really no reflexes on exam. The one I was just mentioning, the Yersinia pestis, the diagnosis is basically like a gram stain or blood culture. And these patients usually is transmissible. One of the problems with this disease is that like back in the 1100s, millions of people died in Europe from this. And then they figured out like, okay, this is related to rats and this is related to the fleas that are transmitted to humans. The incubation was about 1 to 3, but the problem with this disease is that it's transmissible from person to person, and that's what makes it very challenging, and that's why it's being considered a bioterrorism agent. It's usually droplet precautions, and God forbid somebody starts producing this and doing an attack here in the US. Francisella tularensis, when you hear this you hear about rabbits, but you also hear about like humans and bioterrorism. Basically, These occupations that are at risk of tularemia, like lab workers, landscapers, farmers, veterinarians, meat handlers. These patients, they have like a lot of headaches, fever, arthralgia, diarrhea, and can actually progress to pneumonia and respiratory failure. It's not a spread from person to person, and you don't need to isolate, unlike the Yersinia pestis. Smallpox. We don't vaccinate for smallpox. There was like this debate whether or not everybody should be vaccinated again in the US, because it was officially eradicated in the 1970s. But I think the most recent recommendation is that people in the military and people in the healthcare in the military, they are required to get the vaccine. Smallpox is a very contagious illness. Have you guys heard about Palau? It's a nation in the Southeast Pacific. Have you guys heard about Palau? It's a very small nation. Yeah, it's a beautiful, it's one of the smallest nations recognized by the UN. So Palau, back in 1900, like 80% of the population of Palau died from smallpox. And that's one of the most severe outbreaks that's been documented. Right now they have like 40,000 people living there, but it was one of those interesting facts. So smallpox is always going to be like probably the #1 bioterrorism agent, and the lesions are very contagious. I've never seen it. Like in practice, this is a picture like the hemorrhagic type of smallpox lesions. Once you see this kind of severe involvement, for sure the patient is going to die. It's like hemorrhagic pustules everywhere. And lastly, foodborne illnesses. You think about the timing is very helpful. So like just read the question, pay attention to what they're asking you. If they tell you 1 to 6 hours, you think about staph aureus, you think about preformed enterotoxins. But if they give you 8 to 16 hours, you think about the Clostridium perfringens, Bacillus cereus. But if they give you more than 16 to 72 hours, you think about Campylobacter. So Campylobacter, what else? What other setting you see Campylobacter? You guys remember? I'm sorry?
Where do you see it, like when you camp?
Yeah, when you camp. Mm-hmm. And then this disease actually can cause, is a mimicker for appendicitis, because it can cause like right lower quadrant pain and lymphadenopathies. But again, it's one of them. So when you have a patient with diarrhea in the urgent care, and this is important that you guys, I guarantee you're going to be doing urgent care, either to get extra money from moonlighting or as a living, you're going to be doing some urgent care. A lot of the times patients come with diarrhea. The way you manage diarrhea, you get a good history. You inquire about all sorts of exposures, recent travels, like camping, all that stuff. You inquire about whether or not the diarrhea has blood, has mucus, and whether or not they have abdominal pain. If the vital signs, they don't have any red flags, if the vital signs are normal, or maybe they're a little dehydrated, I usually do like a Chem 7 just to make sure they're not severely hypokalemic. Just give them some IV fluids. But the most important thing in the management is that you tell them supportive management. You're gonna avoid dehydration. You're probably gonna prescribe some sort of like oral hydration solutions. But typically we don't prescribe agents to stop diarrhea. Why? Because there is a small chance that these patients may have an infectious diarrhea, like the ones I'm mentioning on this slide, and that's detrimental for the patient. So typically, when you order a stool culture, they report 3 things. They report Campylobacter, they report Salmonella, and they report Shigella, typically. But on the boards, they also ask you about if you suspect, like for instance, like somebody ate like undercooked meat, and you're thinking about enterohemorrhagic E. coli, the one that's associated with hemolytic uremic syndrome. There is a specific test that you can send. It's a stool test that you can send to look for entero. It's called the OH 180. I'm trying to think what it is. 157. Yeah, 157. So you can send a test for that one, but I rarely send it. And but like on the boards, they may give you like some hints. Like if they give you like rice, you think about Bacillus cereus. If you hear about like potato salad or some sort of creamy or poultry, you think about staph. One this is a funny story. When I was on duty, when I was living in Colombia, I was a physician in charge of a small hospital. Like we had like 20,000 people living in that town. So they were celebrating a wedding, and they actually, the dinner was chicken, like some rice and chicken. And it was 11 p.m. I will never forget. They started coming, like, it was unbelievable. There was only 3 of us on duty. And I kid you not, I probably had like more than 40 patients coming at the same time, and they were all like complaining of severe abdominal pain. They all have like staph, like the preformed enterotoxins. They were all like vomiting, diarrhea. That literally looked like a war zone. Everybody was like crying and screaming. So we called like backup, and the firefighters came, and everybody was like cannulating patients, giving them an IV, and everything was like really crazy, chaotic. So, but one funny thing happened is that. The last 2 patients that came in was the groom and the lady, and they were like in the same room. And the lady actually had 2 kids. It was so funny. It was like 2 kids from a previous marriage, and the poor lady was laying down with the 2 kids in the middle, and the groom was next to her, and everybody was throwing up. So I'll never forget that, because this is the classic description how it happened. Like rice and chicken, poultry. You think about poultry, and the onset was fairly quickly, probably like 2 hours after everybody ate, they started like coming, like all of them started coming. It was like a crisis in that little hospital. And again, it's usually staph. When you hear about canned foods, you think about Clostridium. Honey, you think about, the weakness. They may give you a question of a baby that's weak and they feed him honey. You think about Clostridium botulinum. Apple cider and undercooked hamburgers, the E. coli. It's okay, you have diarrhea. Okay, so infectious diarrhea, again, if the patient is healthy, hold on. Okay, like I was telling you guys, your job in the urgent care is to reassure the patient, the family, make sure they avoid dehydration, and then most diarrheas are self-limited, they're virus, and they just go away on its own. If the patient are having like more than 7 days, then you kind of wonder whether or not they have like some sort of parasitic disease or non-infectious etiology. So the typical workup is like you send the patient for a stool culture, OMP, and you do Clostridium difficile. If you think about community acquired C. diff. C. diff is not just in the hospital, by the way. We're seeing more and more C. diff in the community. And if everything, all the workup is negative, that's when you start moving towards like, okay, we need to send this patient for a colonoscopy, maybe a biopsy, just to rule out like some sort of colitis. But who gets the stool culture? Basically, if they have systemic symptoms, like I say, fever, bloody, or mucus stool, for sure, order a stool culture. If they've been present for a long time, also get a culture. And again, Salmonella, Shigella, and Campylobacter, and the enterohemorrhagic E. coli if you order it. Okay, so bloody stools, these are the organisms that you suspect. These are other things, raw eggs and reptiles, Salmonella. The lady who was cleaning my house, she told me that she's from El Salvador, and she told me that they eat iguanas, and that's pretty common. It's very delicious. So I've never heard of like people eating iguanas, but so if you eat reptiles, you have the risk of developing Salmonella. There was an outbreak in the U.S. Years ago related to pet turtles. So if you have pet turtles, wash your hands. Recent antibiotic exposure or recent hospitalization, you think about C. diff. Seafood, remember, seafood and Vibrio in the cirrhotic patient, they may give you that question. Travel, you think about like the traveler's diarrhea or parasitic diseases. Cruise chips, norovirus, this happens very frequently, actually, like at least once a year you hear like the whole cruise is like having diarrhea. Hiking, Giardia lamblia, that's a classic. Freshwater, you have the Aromonas and the pseudoappendicitis, Yersinia. Puppy, kitten with diarrhea. Chicken salad, you think about Campylobacter. Daycare centers, Shigella, Giardia, rotavirus, and norovirus. And Guillain-Barré syndrome, Campylobacter. That's actually a pretty serious complication of Campylobacter. Okay. And you guys know now that this is pretty popular here. Do you guys know what other disease caused Guillain-Barré? Zika virus. Yeah. So it's actually one of the scary things about this virus. Okay. So I'll leave this one for your review. It's just treatment for specific organisms. A lot of the times most physicians, they end up prescribing an oral fluoroquinolone. Okay, so C. diff, I think is the last slide. C. diff is actually a serious disease. C. diff can present from a very annoying diarrhea to very severe colitis and sepsis. There are more and more like virulent strains coming up. I recently had a patient with severe sepsis and severe leukocytosis. These patients, one of the interesting characteristics about C. diff is they get a leukomoid reaction, like the white blood cell count. When you look at these patients when they're in the hospital, it can be 20, 30,000 associated with diarrhea. You're almost certain that you're dealing with C. diff. You don't wait for the stool antigen to come back. You just start treating it. And you guys know the way we treat it is basically with metronidazole. These patients can actually develop toxic megacolon perforation and sepsis. So, important high yield points. If you have foreign stools, don't send it for C. diff. There's absolutely no risk that this is C. diff. Another important teaching point is that you don't send another C. diff just to assess for resolution, because the test may still be positive for another 2 weeks after completing treatment. That's another thing. So another thing important for your boards and for your training is that if you're entering a room for a patient with C. diff, you don't do the alcohol swabs. You have to actually wash your hands with soap and water for about 30 seconds, because they're spores, and that's the only way you can actually kill them. They're highly, highly contagious. They spread all over and that's why these patients require contact isolation. And if the patients are not responsive to metronidazole, we do oral vancomycin. They're like third line and fourth line agents. That's out of the scope of this talk, but like some patients can present with severe multi-organ failure and ileus, or like I said, these patients require like general surgery consultation and aggressive antibiotic therapy. Okay, I'm sorry.